Welcome to The Explainer. Today we're doing a deep clinical dive into orbital cellulitis. This is one of those diagnoses where everything matters. The pathogens, the pathways, the protocols. It's high stakes, so let's get right into it. So, imagine this. A patient walks in with a swollen red eye. You have to immediately ask yourself one fundamental question. Is this just a bad eye infection, or are we looking at a full-blown neurological emergency? Because how you answer that question, well, it changes the entire game plan.
Here's how we're going to tackle this. First, we'll cover the crucial difference between the two types of infection. Then, we'll dig into the bugs themselves, the drugs we use to fight them, and the really scary stuff, the risks. We'll wrap it all up with some key clinical pearls to take with you.
Okay, Section 1, a tale of two infections. We're going to start with what is probably the single most important concept, the one anatomical line in the sand that separates a serious problem from a truly catastrophic one.
First, let's just set the stage. What exactly is cellulitis? Well, at its core, it's a bacterial invasion, right? It's acute, it moves fast, and it gets into the skin and the subcutaneous tissue. You know the classic signs, that intense pain, redness, warmth, and swelling, usually with these really ill-defined borders. And very often you'll see systemic signs like fever and chills, which tells you the body's immune system is in an all-out war.
And this brings us to the absolute key. It all comes down to a single anatomical landmark, the orbital septum. You got to think of it like a biological firewall. As long as the infection stays in front of that wall, it's preseptal cellulitis. It's basically a bad eyelid infection. But if the bacteria breach that firewall and get behind it, that's when it becomes orbital cellulitis. And now we're in a completely different and far more dangerous territory, because the infection is inside the orbit itself.
All right, Section 2, identifying the microbial culprit. So, you suspect an orbital infection. The next logical step is to figure out what organism is causing all the trouble. Sounds easy, right? Well, it's a lot harder than you'd think. And here's the big diagnostic headache. When you take an eye culture, you're pretty much always going to grow something. The problem is, a lot of what grows is just normal flora, the harmless bacteria that are supposed to be living on our skin and in our throats. So a positive culture isn't your smoking gun. This is why clinical context is king. You have to look at the patient's whole story, their history, the likely source of infection, to figure out if you're looking at the real culprit or just an innocent bystander.
So, Section 3, pathogens, the usual suspects. Since the cultures can be so tricky, we have to play the odds. We rely on knowing who the likely troublemakers are based on how the infection started. Let's meet them. Think of this table as your clinical roadmap. If you have a spontaneous preseptal case that just popped up, you're thinking about the common skin bugs, right? Your SA, your S. pyogens. But the source changes the entire equation. Was there trauma? Now you have to worry about a mixed bag of bugs, maybe even anaerobes like Clostridium if there was soil involved. If it's spreading from sinusitis, your suspects pivot to respiratory pathogens like H. influenzae and S. pneumo. And post-op infections, the number one culprit is almost always going to be Staph aureus. Now we're at Section 4, strategic antimicrobial therapy. Knowing all this allows us to be really smart with our initial treatment. We can start antibiotics empirically, but it's not a shot in the dark. It's a targeted strike based on the suspected source and pathogen.
So for a straightforward, uncomplicated preseptal case, remember, that's the one still in front of the firewall, we can often manage this with oral antibiotics. A solid first-line choice is amoxicillin clavulanic acid. It gives us great coverage for the likely staph and strep bugs, and it's usually just a 5-day course.
But the second that infection crosses the septum and becomes orbital cellulitis, the game totally changes. We have to go bigger. We're talking IV admission and aggressive therapy. For an infection coming from a respiratory source, IV amoxiclav is still a good workhorse. But notice the nuance here. If you think it's from a deeper sinus or dental source, you have to hit it harder. We actually increase the dosing frequency to push more drug into those poorly vascularized spaces.
Now, what if the infection started from direct trauma or after a surgery? Well, our list of suspects narrows down dramatically. We're laser-focused on the big guns of skin and soft tissue infections, Staph aureus and Strep pyogenes. And for that, we pivot our strategy. We bring in a more targeted weapon, like high-dose IV flucloxacillin,
to really hammer those specific pathogens. And of course, we always have to adjust for age. Kids are not just little adults. Specifically, in children under 5 who have orbital cellulitis that spread from the sinuses, you absolutely have to consider Haemophilus influenzae. It's a huge player in that age group. So whatever antibiotic you choose, it has to provide robust coverage for H. flu. That's a critical difference from how you'd manage an adult with the exact same clinical picture.
And that brings us to Section 5, grave complications and risks. So why are we so aggressive? Why all this careful, nuanced treatment? Because the stakes are unbelievably high. If you fail to control this infection and control it fast, the consequences can be devastating.
You know, it kind of makes you appreciate that old specialty joke. What's the toughest part about this job? You're always trying to get ahead of the bugs, but they just keep finding new ways to get under your skin. Okay, now let's confront what can actually go wrong.
And these risks are truly sobering. Beyond a local abscess, the infection can spill into the bloodstream, causing bacteremia. It can compress the optic nerve, leading to permanent vision loss. It can spread backwards, right into the cranium, causing meningitis or a life-threatening clot in the cavernous sinus. And in the absolute worst, thankfully rare cases, it can lead to descending necrotizing mediastinitis or even necrotizing fasciitis, a true drop-everything, run-to-the-OR surgical emergency.
This brings us to our final section. Section 6, Prevention and Clinical Pearls. Let's consolidate everything we've learned and boil it down to the most important actionable takeaways. Honestly, if you remember just one thing from today, let it be this principle right here. The distinction between preseptal and orbital cellulitis isn't just some academic factoid. It is the single factor that dictates risk, prognosis, and your entire management plan. Getting this right, and getting it right early, is everything.
Okay, let's lock this in. Rapid review, question 1. A 4-year-old child comes in with orbital cellulitis that clearly extends from sinusitis. Which pathogen should be at the very top of your list of suspects?
That's right, Haemophilus influenza. Just like we hit on in our pediatric spotlight, in this specific age group and with this specific source, H. flu is a major culprit you have to cover. Okay, next question. Let's focus on one of those nightmare complications. For necrotizing fasciitis, what is the single most critical, absolutely essential treatment?
And the unequivocal answer is primary surgical debridement. Yes, antibiotics are crucial, but they're completely insufficient on their own. For a flesh-eating infection, the scalpel is the definitive life-saving tool, period. So I'll leave you with a final thought to mull over. In this high-stakes race against orbital cellulitis, what is our most powerful tool? Is it the microscope for diagnosis, the powerful antibiotic for treatment, or is it simply the clock on the wall, reminding us that every single minute counts? Something to think about. Thanks for joining me.